Welcome and thank you for joining us tonight for this virtual town hall meeting. Tonight we will be talking about a very important topic, committed to cancer research and care during COVID-19, a Sylvester and the PAPCOR partnership. Before I proceed, I am honored to welcome our three guest speakers, Dr. Stephen Neimer, Dr. Sinoj Poonen, and Dr. Lazarus Lukakus, and our moderator, Kay Rentz. Dr. Stephen Neimer is the director of Sylvester Comprehensive Cancer Center, the Oscar de la Renta Endowed Chair in Cancer Research, and the Professor of Medicine, Biochemistry, and Molecular Biology at the Miller School of Medicine. Under Dr. Neimer's leadership, Sylvester received the prestigious National Cancer Institute designation, NCI, in 2019. And he is a world leader in the treatment and genetic basis of adult leukemia and bone marrow failure states. Dr. Sinoj Poonen is an associate professor in the Department of Urology at the University of Miami Miller School of Medicine. He is the co-chair of the Genital Urinary Site Disease Group at the Sylvester Comprehensive Cancer Center. And I am proud to say, Dr. Poonen also holds the inaugural PAPCOR Champions for Cancer Research Endowed Chair for Solid Tumor Research. Dr. Lazarus Lukakus is an associate professor in the Division of Stem Cell Transplantation and Cellular Therapy at the University of Miami Miller School of Medicine. He is the leading U.S. investigator for the first bispecific Carte therapy against relapsed lymphomas and has performed more than 550 stem cell transplants and cellular therapies. You know, for 68 years, the PAPCOR has played a vital role in supporting groundbreaking research at Sylvester. I am proud of what we do at the PAPCOR. I am proud to be part of such a great organization, and I am proud that we are committed to helping Sylvester find a cure. Those who are battling cancer are looking at organizations like ours and cancer centers like Sylvester to help them defeat this horrible disease. Those who are celebrating milestones of being a cancer survivor are looking at both of us to help them remain cancer-free. The PAPCOR's main and only purpose is to help fund cancer research at Sylvester Comprehensive Cancer Center. Now, I know it is difficult during these trying times to think about anything other than COVID-19, but cancer hasn't taken a break, and neither can we. Our support is needed now more than ever. So now let's get our program started. Please welcome Dr. Stephen Neimer, Director of Sylvester Comprehensive Cancer Center. Dr. Neimer.
Thank you very much, Susan, and thank you, Kay. It's a pleasure to be joining everyone virtually tonight. You know, the one thing in particular I'm going to miss is the rugula that I usually get when we get to meet in person. And over the 8+ years that I've been directing Sylvester, we've had many opportunities to talk about some of the programs and some of the people, programs that we've built, people that we've recruited or who are doing really amazing things. And tonight we have an opportunity to share some of that with you. We have two amazing faculty members, Sinoj Poonen and Lazarus Lukakus, who are going to talk to you about the research that they do. You know, the partnership with the PAPCOR is one of the most important for the entire university. over $100 million has been raised for Sylvester. And in 2016, we had this incredible $50 million pledge that we agreed to. And I can assure you that COVID or no COVID, that the people at Sylvester are working tirelessly to develop new therapies. Across the health center, there have been areas, for instance, the governor for several months prohibited elective surgeries, but cancer treatments and cancer surgeries are not elective. People need to have their treatments, and we've been operating at about 98% of the pre-COVID numbers in terms of the number of treatments that we're delivering and things. And it's really important that we continue to offer new, less toxic treatments, more targeted therapies, more curative therapies, and the partnership that we've had with the PAP Corps has been absolutely essential in terms of us advancing our efforts. You know, traditionally we put about 500 patients on clinical trials in a year, what we call interventional treatment trials. And during the COVID-19, we've been able to open 43 trials and enroll over 150 patients, not quite at the normal numbers, but still to be able to treat hundreds and hundreds of patients at the same time that we're caring for patients who have COVID. Unfortunately, you know, we've had to restrict lots of things in the way we take care of people. One of the more difficult is the absence of visitors. And so people who are coming in to get chemotherapy, coming in to see the doctor, are not allowed visitors with them. We've put in place all kinds of things. In fact, we have, when the COVID first hit, we stopped all our valet parking because the valet would go into one car and another and could easily transmit COVID from one to another. We have used our NCI designation to great success. This year alone, we've gotten over $1 million of additional funding that we have applied for and been successful. We've also been able to recruit even more colleagues for us all. Our phase 1 clinical trial program is expanding, and we are going to launch an experimental therapeutics program. Now tonight, you're going to hear different aspects of research from our my two colleagues. You've heard about Dr. Lukakus briefly. He is one of the most prominent stem cell transplanters in the state of Florida, and therefore in the United States. And he has also been a leader in our cellular therapy efforts, and he'll explain what that refers to. And Dr. Poonen, as a urologic surgeon and a cancer researcher, has been trying to understand, in part, some of the differences, you know, why if two men with prostate cancer, why the prostate cancer has a similar appearance under the microscope, but can behave so differently, and how does one begin to understand for bladder cancer, prostate cancer, and all these cancers, how do we find the right treatment for the right patient? We talk about precision medicine, and he is one of the leaders in our efforts to link the right treatment for the right person. And so we're delighted to have an opportunity to talk to you, to answer questions. Kay, we thank you for moderating, and without further ado, I'll turn things over to you.
Thank you so much, Dr. Neimer, for your important message this evening. And good evening, Susan, and hello to all my fellow PAP Corps members who've tuned in for the ultimate house call. Tonight, we have an esteemed panel who'll be taking your questions, and they'll be talking about, as Dr. Neimer said, advances in experimental therapies, precision medicine, and immunotherapy. Now, I know many of you sent in your questions with your RSVP. But there is an opportunity tonight to ask a question in the Q&A on the bottom part of your screen. Please keep your questions broad-based, as the doctors can't answer personal questions about your medical care. Tonight, we're going to try to get to as many questions as we can, but if we don't get to yours, someone from Sylvester will reach out with a reply. So let's jump right into it, okay? Our first question is for Dr. Lukakus. Doctor, please briefly describe Cardi Therapy.
So with Cardi Therapy, we take advantage of the immune system to recognize specific antigens in the surface of cells. So we take lymphocytes out of the body of the patient, and we insert viral vectors, and we, through the viral vectors, we put genes inside the lymphocytes. And now those lymphocytes with those genes are able to recognize specific proteins expressed only on cancer cells. And this doesn't happen with many cancers, but happens for sure with the cancers of the hematopoietic system, with blood cancers. So now we have lymphocytes that they recognize, for example, CD19 on the surface of leukemia or lymphoma cells. We grow those cells, we make them potent, we put co-stimulatory molecules, and then we take out, we try to kill the lymphocytes that have remained on the patient to provide extra room for those educated lymphocytes to come back to the body, start multiplying and attack the tumor. So we give a little bit of chemotherapy, and then we infuse the Carte cells, and the Carte cells go exactly where the tumor is, and they start opening holes in the surface of the lymphoma or leukemia cells, and they kill them. So this is the, seems complicated, actually is a simplistic explanation. We try to combine now this approach of Carte cells with other treatments, for example, with checkpoint inhibitors to try to keep them longer in the body to fight the lymphoma. And with this approach, we're able to cure otherwise incurable lymphoblastic leukemias or B-cell lymphomas, especially the aggressive ones, that even transplant wouldn't be able to cure those cases, those patients.
Well, that sounds like an extraordinary development. Thank you so much. The next question is for Dr. Poonen. And Dr. Poonen, this is actually a two-parter for you. First part, are most doctors still making decisions about prostate biopsy based on PSA? And what do you do in your practice to decide who needs a biopsy and who doesn't?
Great question, Kay, thanks. First of all, I'd just like to thank you and Susan and Dr. Neimer for your efforts in hosting this, and the entire PAPCorp membership, you know, for all that you guys do, because I know for a lot of our research, it just wouldn't be possible without your efforts. So I'm glad that you guys get to share in some of this today. But to your question about PSA, so PSA, for those that may not know, is a protein that we can look for in the blood, and we use it as physicians to screen for prostate cancer. So if a PSA is elevated for a person's age or man's age, we may say that there's a risk of prostate cancer and we need to look for that. The problem is how we look for it is a biopsy of the prostate. And in many places, this may mean, you know, an invasive procedure that can cause some side effects, which a lot of guys won't want to go through. And the problem is we know now that the majority of time this PSA test goes up, it's because of benign reasons, because the test, while it's very prostate specific, it's not cancer specific. So what we've learned is if you use that only to do biopsies, you end up biopsying a number of men unnecessarily. So we tend to use other tests to help us decide who needs the biopsy and who doesn't. One of the major areas, I think, in that space is MRI of the prostate, because that allows us to look at the entire prostate. If we see something, then we can actually target it on the biopsy. But we've also seen some biomarkers that are in the urine, in the blood, that are a lot more specific compared to PSA, and those can help as well to help decide who needs the biopsy and who doesn't.
Well, thank you for clarifying that. That sounds like a lot of remarkable things are happening in that area as well. So our next question, we're going to go back to Dr. Lukakus, and we're back on Carte again. This question asks, what are the FDA indications of Cardi therapy in adults with hematologic malignancies?
For relapsed refractory diffuse large B-cell lymphoma, which is the most common lymphoma in the United States. And there are patients who don't respond to the conventional chemotherapy, and or they respond and they relapse. And when they relapse, usually we give them more chemotherapy to try to get them to the transplant, to the autologous stem cell transplant, but sometimes they don't respond. So those patients who either don't respond from the get-go, or who relapse and don't respond to salvage chemotherapy, or those who have gone through the transplant process and they have relapsed later. For those, we have an indication to use anti-CD19. CD19 is a protein expressed on the lymphoma cells, Carte cells, so Carte cells that recognize the CD19 on the surface of the lymphoma cells. And we have two products. One is called Carte, or axicabtagene ciloleucel, and the other one is called Embryo. And also some other rare lymphomas, transformed follicular lymphoma, that is also relapsed or refractory. And also we have an indication for primary mediastinal B-cell lymphoma, which is a rare tumor. Also, we can treat patients up to the age of 25 with relapsed or refractory acute lymphoblastic leukemia. Those are the main indications, FDA indications for the use of Cartisal therapy. We try them in many other diseases. We try them in myeloma. We try them in, we'll start trying them in T-cell malignancies. We try them in acute myeloid leukemia. But the main, and there are some other cells like Cardi cells that we try even in solid tumors. We have done that here in Sylvester with some long-term survivors. But the FDA indications are relapsed refractory aggressive lymphoma and acute lymphoblastic leukemia up to the age of 25 years old.
So Dr. Lukakus, you gave us some parameters on that, but we do have a follow-up question, and I'm not sure if you kind of answered it towards the end or not, or if you want to go into it a little bit further, but one of the questions came in, can Cardi therapy be used in other cancers?
Yes. We have, for example, Cartisal therapy against multiple myeloma that will be approved relatively soon, I believe. Recognizes a different protein that is called BCMA and in the myeloma cells. We have also some Carte cells against acute myeloid leukemia. Some of them try to recognize CD33, another protein CD123 that supposedly is expressed in some of those leukemic stem cells. There is another one that targets CD70, 70. We try cells that engineer T cells that target tumors that are expressed in tumors more than in normal tissue. We have such cells against the so-called tumor testis antigens, cancer testis antigens, NY-ESO-1, and some other proteins, LAGEs and MAGEs. And we have tried it we have tried those cellular therapies already in lung cancer, and I have a survivor of such a procedure 3 years now with stage 4 adenocarcinoma of the lung. We infused him twice, and we tried it in synovial sarcoma. We have other cellular therapies similar also to the Carte cells, the tumor infiltrating lymphocytes that we take directly from the tumor, and we educate them outside the body of the patients, and we give them back with interleukin-2 after some chemotherapy. And we have a survival with cervical, metastatic cervical carcinoma in the liver, almost 2.5 years now after the procedure. And some of those are really tough procedures, but yeah, we have tried it. But those are not FDA approved indications though.
Thank you, Dr. Lukakus. Actually, you've explained things so brilliantly. We're getting a lot of questions coming in about this topic, but we're just going to divert just for a minute and just jump back to Dr. Poonen because we have another question coming in for him. So Dr. Poonen, they asked, there are all kinds of new tests and treatments for prostate cancer out there now. How are we supposed to know which ones are the best? That's a really good question.
Yeah, that's a tough one. Well, I think this is why one of the things that makes prostate cancer an exciting space to work in, because there are so many new things that are coming out. But as you alluded to, one of the difficult parts is knowing which is the right test for the right person and the right treatment as well. So as I mentioned before, in the past, all we had was PSA. And based on that, we do a biopsy. And then if you saw cancer, you'd make a decision based on how much cancer you saw and how aggressive it looked. Now we have, as I mentioned, urine tests, blood tests that can help us decide better than PSA whether someone has cancer and to some degree how aggressive that cancer could be. We have MRI and other imaging tests that can help localize the cancer in the prostate, because one of the issues with prostate cancer is, unlike kidney cancer, lung cancer, which forms like a ball, prostate cancer spreads out like fingers around the ducts. So it's always evaded imaging detection on ultrasound, CT scans. So MRI brings in certain functional features like how thick a tumor is or how much contrast or blood flow it gets. And with all these things put together, we can actually say, we think this is the area where the worst tumor in your prostate could be. And so you get much better sampling on the biopsy. So in the end, I think depending on the space you're in, there are certain tests that are going to be better for you. So if you're in a situation where your doctor is trying to figure out whether you have prostate cancer, urine or blood tests, in addition to PSA and this MRI, can be the area. If you have a prostate cancer and you're trying to figure out whether you need to be treated, there's genetic tests that you can actually do on the tumor itself, and it'll tell you whether the genes of that tumor appear more aggressive or more indolent, and that can help you decide what the right treatment may be or whether you need it at all.
Wow, that is fascinating. And I know that's going to be very helpful to the people who are asking these questions right now. We're getting more questions coming in on this topic. But right now, we're just jumping back to Carti therapy again, to Dr. Lukakus. You gave us a great background about Carti therapy, but someone just asked, what are some of the complications of Carti therapy?
In the beginning, we are very scared with those complications. But now we are getting used to them and we know how to treat them better. When those cells start killing tumor, we may see this, the so-called cytokine release syndrome. What happens there is chemicals are coming out either from the dead cells, dead lymphoma or leukemia cells, or from the Carti cells themselves, or from other immune cells in the body. And there are a lot of chemicals, interleukin-6, TNF-alpha, interferon gamma. Those can drop the blood pressure, can impair the oxygenation, it can cause fevers, which is usually the first sign, and can cause effusions in the body, fluid accumulations in the body. And when we start seeing that, usually we give an antidote, an antibody, a monoclonal antibody against the main mediator of this syndrome, which is the interleukin-6. So we give an antibody against the receptor of interleukin-6. We call it tocilizumab. The fever usually goes down, the blood pressure improves, but sometimes we have to support patients with fluids and with medications to keep the blood pressure up. If the tocilizumab doesn't work and this cytokine release syndrome gets worse, then we have to give intermediate doses of corticosteroids. The problem is that we don't want to give so high doses of corticosteroids because we may kill the Carte cells. But we give enough corticosteroids to stop this reaction. If this doesn't stop, then we have to give high doses of corticosteroids, and then we know that a lot of Carte cells will be killed. But safety is first, and we have to keep the patient alive. So that's the cytokine release syndrome. The second problem that can happen is neurological toxicity. And happens more frequently with anti-CD19 Cartisal therapy. It doesn't seem to happen so often with other cellular therapies, with other Cartisal products. And seems that the Carte one, which is very active, can give more neurotoxicity than others. But patients start forgetting things, start forgetting how to do things, start forgetting how to make calculations. Sometimes they are lazy, they want to stay on bed all day. Sometimes they forget even how to button or unbutton their shirts and to go to the bathroom. And it sounds scary, and it is. But usually by giving steroids, this one is totally reversible. There is 1% of patients who may develop cerebral edema. And this is a potentially lethal complication of this procedure, is 1%. So those are the main two toxicities: the cytokine release syndrome, again, that creates fever and drops the blood pressure, and the neurological toxicity, we call it ICANS syndrome, that can make people confused, forgetful, and not able to do simple tasks, but sometimes can go to coma and cerebral edema. There are other complications. Sometimes the immune system can get so much activated that can drop all the blood counts and can create a life-threatening complication. We call it Hemophagocytic Syndrome. And sometimes also we see low blood counts for a long time, and people may need to receive growth factors and transfusions. The treatment-related mortality in the initial papers is about 3%. Probably with the experience we have now to go against the complications, we have reduced it. The other possibility that the other side effect that can happen is infections, because the immune system goes down. And this can happen either during the initial phase as bacterial infections, or later on as viral infections, or even fungal infections. The levels of antibodies, of natural antibodies in the body goes down, and sometimes we have to replace them with intravenous immunoglobulin. So it's a complicated procedure. It has to be done in a specialized center with experience, especially experience on treating the complications. But in good hands, it's a relatively safe procedure.
Dr. Lukakus, yes, it does sound complicated, but it's very reassuring to hear you talk about all the different protocols and the different things that you do to help patients through their cancer and through the therapies. And if they do have complications, you're there guiding them through it. So that is something that is really wonderful. And thank you for explaining that. So we have another question that came in, and this is for Dr. Neimer. So Dr. Neimer, they ask, can you use CRISPR to change the DNA of cancer?
Okay, well, that's a very interesting question, and I'm going to answer it in a little bit broader context. So you may have read about CRISPR technology. It's an amazing way. It's sometimes referred to as gene editing. And so we understand that cancer can be caused by genetic mutations. And the thought is, can you use basically what is a like scissors and glue to eliminate the area where the mutation is and put the gene back together so it becomes normal. And that's what CRISPR is. So the problem with using CRISPR in cancer is that you really have to treat every single cancer cell in the body. And there are ways of doing CRISPR in a mouse. There would be ways of doing it in a human, but to actually treat every cell, it's probably beyond our capability right now. The other thing is that the scissors or so that CRISPR is to cut out the abnormal piece of the DNA sometimes nicks other parts of the DNA, and it doesn't only go to where you want it to go. You may have read that people are using CRISPR to correct gene abnormalities in the embryo. There were some very controversial studies out of China that did that. CRISPR is being used potentially for a form of Carte cells where you know, if you have a T cell cancer, the Carte cell could sort of go back on itself and eat itself. And so there are ways of making the Carte cell resistant itself to Carte cells, and then it can go after T cell cancers. So CRISPR is being used in a lot of ways, not really yet for cancer cells. And the other thing is, part of the CRISPR is the targeting to the gene abnormality. And so CRISPR is now being used for some of the COVID tests. So if you design what we call a primer to recognize the COVID virus itself in a sample, so in a nasal swab, you can use CRISPR to see whether the virus is there or not. So nowadays you may read about the FDA allowing some CRISPR-based detection of COVID testing, but it's still in its infancy. It's used all the time in the laboratory, and it's a very powerful technique that will help us in our cancer research.
Thank you for that explanation. As I said, yes, it's been in the headlines a lot. But one point that you made that I thought was fascinating when you said maybe it's beyond our capabilities right now, but you see the potential with everything that's coming with that, so that in a few years, the progress that will be made, it seems very exciting.
You know, Dr. Lukakus has talked extensively about Carte cells. It's a new technology. If we were having this call 10 years ago, nobody ever heard of a Carte cell. 10 years ago, nobody heard of CRISPR. And so it's a very exciting time because the drugs that we're developing, the phase 1 drugs, are working. The combinations are working. And as cancer doctors and researchers, the three of us probably have never been excited about the future as we are right now. Thank you.
That is wonderful, and that will inspire all of our PAPCOR members. So we actually have another question that just came in from one of our members, and this is to Dr. Poonen. Dr. Poonen, one of our members writes, I was diagnosed with prostate cancer that my doctor thinks I can watch. Does this mean I will still need a biopsy every year to make sure the cancer is stable?
Yeah, that's a good question. So most prostate cancers, I mean, you guys may have heard the saying that you die with prostate cancer, not from prostate cancer. And there's a lot of truth to that. I'd say the majority of prostate cancers that get diagnosed are in the prostate alone. They're very indolent and they're going to have a very growth rate. So we do feel comfortable watching them. The problem is that when we do biopsies, for the most part, now with MRI it's a bit better, but it's somewhat of a random sampling because, like I said, imaging doesn't always cancer. So you always have to be somewhat concerned that the prostate that you just did biopsy may be a bad outcome if you watch it. That's always one kind of potential to worry about there. Now, I think over time, we've realized that, as Dr. Neimer said, no two patients are going to come exactly the same. And some men are going to have cancers that are going to be very indolent and their progression time is decades, and others are going to have ones that go more aggressively. We've used genetic tests, various molecular tests and other things like that that help us decide which kind of group guys are going to fall into. So we have an ongoing trial now that has about 200 guys on it watching their prostate cancer, and we get serial MRIs, we do biopsies, we get urine and blood tests on them, and we're getting genetic profiles as well. And I think in the end, we'll be able to help or get some understanding of which tumors go in which directions and how we can use these tests to tell whether they're going to do that or not. So for guys who appear to have very low risk of progression, we can really de-escalate their monitoring so that they don't need to be biopsied every year and just infrequently, compared to guys who have a slightly higher risk of progression who may need to have more, serial monitoring.
Well, I thank you, Dr. Poon. I think that's going to be a relief to a lot of our listeners right now to know that you're really able to target even how much watching needs to be done on different things moving forward. So that's very exciting. We have more questions coming in for you, but we just got another one coming in for Dr. Neimer. And our PAPCOR member wants to know, what are those NCI designated benefits that are helping Sylvester advance basic science discoveries, clinical trials, and cancer treatment?
Well, thank you. I know that the PAPCOR has heard me talk about NCI designation, and maybe they can't get enough, and I'll never get tired of talking about it. But I think, one of the most important things for our community is the ability to have experimental therapies that are only available at NCI designated cancer centers. And so we just got a supplement, actually $500,000 from the NCI on top of the grant to do, it's called the catch-up. The government likes to use abbreviations. It's CATCHUP, not ketchup like mustard. And this is $500,000 for us to meet the needs of our community and to bring drugs from the NCI here. The work that you've heard about from both Dr. Lukakus and Poonen are funded by funds from the Cancer Center, from the NCI, and that we are the newest member on the block in terms of NCI designated cancer center. And I can also say that there have been others that have tried to join the club, but they have been turned down, and we've been told that we've set a new standard for what it takes to become NCI designated. And so it's an objective bit of evidence that we've achieved greatness, and through our ability to recruit and to open up new trials, it helps us achieve greatness in the future. And I would point out, this grant needs to be renewed every 5 years. And so we're already working on that. We're about 1,100 days away from submitting our renewal application.
Well, I know, speaking from all the PAPCOR members, we are so happy you're in the club, and we remember all the hard work, and you're talking about what it took to get this designation, and we are just so grateful that you did. And we have more questions coming in, so let's just get on to our next question. So our next question, we jump back to Dr. Lukakus. Dr. Lukakus, a little bit earlier on, you were gently mentioning about the stem cell transplant, if I can say it. We have a question coming in that if someone with lymphoma relapses after a stem cell transplant, can Cardi therapy be curative?
Yes. About 37% of those patients can be salvaged, can be cured with Cartisal therapy given after the autologous stem cell transplant failure. It's interesting because the Cartisals, they don't care if someone has gone through transplant. They don't care if someone has some specific genetic rearrangements, the so-called double hit lymphoma. They can be killers in many instances. So the answer is yes. Patients who have failed autologous stem cell transplantation can be salvaged and can be cured with Cartisal therapy. And actually, I have salvaged someone even after allogeneic stem cell transplant. I did it off-label. Someone had CLL and Richter transformation. We did an allogeneic stem cell transplantation and relapsed. And even though they say, well, in CLL, the CAR-T cells don't work so well, I gave CAR-T cells, and the patient is alive in remission now. And so even after allogeneic stem cell transplant, we have done that. Going back to the gene editing thing, actually, we have a trial now that uses CAR-T cells from other people. We call it allogeneic CAR-T cells. Actually, those people already have donated their lymphocytes. The CAR-T cells have been made, and they can be available in 48 hours or something. The autologous transplants, the autologous CAR-T cells usually takes 3 weeks, sometimes more, to be made. But with this product, the company used the gene editing technique, something similar to CRISPR that we call TALM, to take out the T-cell receptor. Because if we use someone else's immune cells, those immune cells can attack our body, and not only the tumor, and can create something we call graft versus host disease. Mm-hmm. So one of the 2 genes that we knock out with this gene editing technique is the T-cell receptor of those allogeneic, someone else CAR-T cells to be able to give them safer. The clinical trial is going well, and apparently 30 to 35% of patients go to complete remission with this specific product. We just opened this trial here.
That is just fascinating news, and our watchers are intrigued by what you're saying. And I think you touched on this, but there is a follow-up question. It's, what is engineered CAR-T cell, and how is it different?
All the cells, all the CAR-T cells are engineered. There are some other treatments similar to CAR-T cells that we call them engineered T-cell receptor cellular therapy, in which case this is usually for solid tumor cellular therapy. We take again the lymphocytes, and instead of giving them a chimeric antigen receptor, the CAR, we put inside the lymphocyte a second T-cell receptor. The T-cell receptor recognizes antigens presented by some molecules we call HLA. So there are some antigens specifically expressed by solid tumors. The second the second receptor, the one that we put, the one that we engineered inside the cell, can recognize those antigens in the surface of the malignant cells and can attack. And this is how, this is the treatment actually I used for this lung adenocarcinoma patient who is alive now 3 years later. Yeah, we do some interesting things here.
You can say that again. You do some interesting things there. I just love watching your face when you talk about your patients and the different techniques you're able to use to save them and give them more life. I mean, just watching you smile up like that is just, it's phenomenal. We are still getting more questions and we have another question coming in, and this time it's for Dr. Poonen. And Dr. Poonen, this is one of those, like, you know, two-parter questions again. The first part, the Popcorn member asks, what is new in the treatment of prostate cancer? And are there any ways of treating prostate cancer that don't have all the side effects of surgery and radiation?
Sure, it's a good question. There's a lot of new things that I think have come out in prostate cancer. I think one of the major exciting things is whenever prostate cancer is metastasized or found to have left the prostate, it can be very difficult to control. And typically traditional chemotherapies don't always work the same. And actually agents or treatments that are geared around testosterone or really taking away testosterone, which is what fuels the tumor, are where a lot of the main management is. So we give medication that actually gets rid of a guy's testosterone, and that will keep the tumor controlled for a period of time. But after a while, these tumors learn to become, you know, resistant to that, and they can grow in that environment. And in the past, there was not much we could offer those patients, and that's when they would have to go into chemotherapy, and that had minimal added survival. But now there are newer agents coming out like almost every few months that add prolonged life and don't have a lot of significant side effects to it. So when these hormones fail, there are more and more that we can offer a patient before having to go to more toxic therapy. So that's an exciting area. I think more towards your second question about trying to avoid more radical therapies like radiation and surgery, you know, in the past, those were the only things that we had. So even if you found a very small cancer in one little part of your prostate, we didn't really have a way of delivering effective treatment to that part of the prostate. So we take the whole prostate out or we radiate the entire thing. Now we have found ways either through freezing parts of the prostate or hitting it with these ultrasound waves that heat it up to actually ablate just a portion of the prostate and spare the rest of it. And as a result, the side effects are drastically lower in these guys, but they have to be very well selected, you know, because it's a treatment for the right type of patient. And that's what a lot of our work is, figuring out what's the right type of treatment for each patient.
And that is so important because you see more and more, it's getting so precise and getting so tailored to the person. And that's really exciting. I love the term that you use about the new agents. And I think that just makes us also hopeful about all the research that you are doing. So we have another question that's come in. We're jumping back to Dr. Lukakus. The question was, what are the future directions in Carte research?
So one I mentioned already, to use allogeneic off-the-shelf Carte cells that the patient sometimes cannot wait 3 weeks. The other one that we have here, and actually we have enrolled more patients in the country, is bispecific Carte cells. So now we have a lymphocyte Carte cell that has two CARs, two different chimeric antigen receptors. Because sometimes a subpopulation of the cancers may not express the antigen that the lymphocytes attack against. So now we have two CARs, we attack two antigens. So we attack the CD19 on the lymphoma and the CD22. So in case in case a lymphoma cell is CD19 negative, 90% of those express CD22. So those will be killed by those bispecific Carti cells. We combine this approach with a checkpoint inhibitor, pembrolizumab, that we give the day before we infuse the Carti cells. And so we keep the Carti cells longer in the body, and we prevent the exhaustion of those cells. Because sometimes from killing, they become exhausted, but now with this pembrolizumab, we avoid the exhaustion. The other area that I see success in the future is combination of Carti cells with other targeted therapies in the field of lymphoma or leukemia. For example, now we have toxins against other targets. We have a toxin against CD79B, the so-called polatuzumab. We can combine polatuzumab with Carti cells theoretically. Of course, we need to make the appropriate clinical trial. Also, we can, there are some other antibodies that bring the T cell close to the lymphoma. We have a molecule that is called mosunetuzumab. By giving mosunetuzumab, we bring the T cells close to CD20, which is another antigen of the lymphoma cells. And most of those cells that will come close to the lymphoma will be Carti cells. They will also recognize the CD19 or the CD19 and the CD22. So now we will have double or triple targeting of the lymphoma. I write some concepts, LOIs for companies to see if we can start some of those trials here. But I think the future is in combination therapy. The other thing is to understand better the mechanisms of toxicity and see if we can prevent that. For example, I haven't realized well why some patients stay with very low blood counts for weeks after the procedure. Probably no one knows the exact mechanism. We need to delineate this mechanism and see if we can prevent it. Also, we don't know exactly the mechanism of neurologic toxicity. If we knew it, we could probably prevent that. Yeah.
Absolutely fascinating. It just really seems like so many things are coming together right now at this time, and there's so many things on the horizon. So I know we're all extremely thankful. We have another question that has come in for Dr. Poonen. And the question was, how many years of research did it take to get to the point on these trials that you've been doing?
So the MASS trial, which is the one where we're observing men with their prostate cancer, each person probably spends about 4 to 5 years on that trial, having their individual tumors monitored over that period of time. So that's how long the trial goes. And as Dr. Neimer mentioned, it is funded by the Cancer Center and by NCI. So a lot of the type of tests that patients may not have access to, we've been able to cover. So we can learn how they help follow these tumors and how we can use them to kind of be more precise in how we manage each person and their individual tumors. So I would say it's been probably about 5 to 6 years of data that we have, and we just enrolled the last person, which is number 200, and he will continue to give us another 4 years, and we'll learn a lot of things kind of each little bit of the way as we kind of look at the various pieces of data that we get and how we bring it in. And I think a lot of the things is, this is stuff that we've been doing just at Sylvester. The next step is going to say, what we learn here, can we start to apply it to other places and more multi-institutional trials? And that's where the NCI designation and being, the kid on the block is going to be extremely helpful for us.
No, that is, and all the collaboration that will come. So
absolutely.
Yeah, when we say research matters, it really does, all the phenomenal work that you're doing. We have this question that had just come in for Dr. Neimer. Dr. Neimer, our member asked, can you elaborate on how philanthropy elevates the impact and outcomes of clinical trials and general cancer research?
Well, thank you, Kay. Let me follow on Dr. Poonen's remarks. So if the trial's been going on for 5 years and they just enrolled the last of the 200 patients, then the trial will be another 5 years. So it's going to be a 10-year trial in terms of getting all the information. And then once it may take another 6 months to analyze all the data and then to report it to the community. And so what I would say is there's an expression called low-hanging fruit, right? Everyone knows about the low-hanging fruit. In cancer research now, it's been plucked already. And so based on all what's been done in the past, there aren't easy ways of making progress right now. We have a drug that works 50% of the time. If you have a drug that works 55% of the time, that may be a big advance, but you need hundreds and hundreds of patients to show a difference. And that's what's happening repeatedly. So the trials are more complicated. The monitoring is more complicated. And there's two things. One is everyone understands that more complicated normally means it costs more. Now, it may cost more to do the study, but if we can find drugs that work for everybody, that means we don't have to give people drugs that aren't going to work. And so the cost to the patients goes way down because if everybody can get a drug that's effective, then we're not experimenting, so to speak, with these drugs, right? You know, aspirin works most of the time if you have a headache, or Tylenol, but not all the time. And if someone has a migraine, they may need something other than aspirin. And that's what we're trying to get to, so everyone can have a treatment. The other thing besides what we call personalizing or precision medicine is speed. So everyone knows of loved ones or friends who've had cancer and who've run out of options. And I can tell you that for all the patients I've taken care of in my lifetime as a doctor, when I meet family members after someone has died of cancer, the first thing they ask me is, if my loved one had cancer now, would the treatments be any different? And the answer is almost always now, yes. There are more things for everybody. And so the philanthropy helps us speed things along. A trial, now Dr. Punin's trial may take 10 years, but sometimes philanthropy makes the difference between a 3-year trial and a 2-year trial. And then for some cancers, getting an answer a year quicker is going to save tens of thousands of lives. And so we're in a race. And what helps us in the race is not only to write for and get the NCI grants and everything else, but to get philanthropy. Companies sometimes prioritize diseases that are more common. But if someone you know has a cancer that's not common, it's irrelevant how common it is in other people. So the relationship with the PAP Corps has been essential, and it's fundamentally speeding up the discoveries.
Sorry, I got a little emotional there. What you said really hit home for me on a personal level. I just want to thank all of you for your dedication, for what you do for all of us, for our family members, for someday some of us in the future. And just it's been such an inspiring and fascinating night. I just want to thank all of you for participating in this, and it's my honor to throw the screen back to Dr. Neimer for his closing remarks.
Okay, well, let me thank you, Kay and Susan and everyone from the PAP Corps. You know, we look forward to the time when we can get together in person, but the fact is that we're here for the community, the partnership that we have, which extends, you know, decades and now century, you know, is really so important to all of us. Thank you for your interest in the work that we're doing. Thank you for our support, and know that we're all very grateful and will continue to work tirelessly.
Thank you. Before I say goodnight, I just want to thank all of you for joining us for this most informative town hall meeting. Again, thank you, Dr. Neimer, Dr. Poonen, and Dr. Lukakus for sharing with us some very interesting, and as Kay said, very inspiring information. And Dr. Neimer, fingers crossed for the next 1,100 days as you reapply for the NCI designation. It seems unreal that you've had it for 1 year and already you're thinking about the next turn. Thank you, Kay, for being our moderator tonight. You were terrific as usual. Our partnership with Sylvester is one of mutual respect and trust. And thus the PAPCOR has been tirelessly working to continue our fundraising efforts, even during this pandemic. And I have to say how much I appreciate to the task force that has been working and to all of our members who continue to support us. So good night. Once again, thank you for joining us. Have a good evening. Please stay safe and healthy.